Thank you, Reiner, for those kind words. I was going to start with a joke, but then Anne broke a finger, and so that's it. So don't mess with her. So I think we're living in a very, very privileged time where I think part of the reason Harvard tends to be a conservative institution, part of the reason why they would create this new institution, a Department of Biomedical Informatics at the medical school, is because we recognize that medicine is, at its core, a knowledge processing and data processing enterprise. And when we do well for ourselves, for our patients. When we do it poorly, bad things happen. And perhaps the most visible instance of this thinking about medicine as a data processing and knowledge processing business is illustrated by the slide here, where we have multiple data types that we have to bring together to give a much more holistic view of patients. This was summarized just this past, not this January, but January 2015, where I had the privilege to be in the White House when President Obama launched the Precision Medicine Initiative. And what's that about? It's basically about bringing our data together at the patient level so that we can see multiple sides of ourselves. It turns out, if I know your genomics, that's not very helpful if I don't know if you're walking a lot. If I don't know your medications, it's not very helpful to know your history, and so on. So bring that together is a top-level initiative at literally the White House level. And that initiative is now going live, and there'll be 1 million patients, we hope, in 5 years, 1 million participants from American citizenry participating. Hello? Whoops. There's lag. So the summary of my talk. I first want to convince you of the opportunities to advance medicine and the need to advance medicine. I'm going to talk about then the socio-technical challenges in health IT and how hosted services, aka cloud services, are going to be key as we go beyond any single practice or any single hospital. And paradoxically, going against everything I had ever been told in the last 20 years, this third-party hosting is being driven by security more than anything else. And an important thing for you to know, because like you, I take this community for granted, except on days like this when I see all of you in the room. You don't understand the richness, because I don't understand the richness of this community. And I will close by telling you about the work of multiple participants in this community, most of which I still don't know, who helped us achieve truly transformative effects at the national level. So this is now the motivation part of it. So using this I2B2 system, which I'll talk a little bit more about, we looked at 2 of our best hospitals in Boston. Let me stop. Let me start from a different angle. I think it was 2 years ago, maybe 3 years ago, an Airbus from Air Malaysia went down into the Indian Ocean. There was 24/7 coverage of that event, and rightfully so. A whole Airbus of passengers disappeared, and we didn't know what had happened. So what if I told you that this graph, using I2B2, looking into our healthcare system, we found out that there was not one Airbus of patients, in this case, that had disappeared, but approximately 700 Airbuses full of patients. And then, what is this? This is the heart attack rate. There was this huge rise in the heart attack rates, an 18% increase in heart attack rates, went up and down. So this is 700 Airbuses full of patients. This is us. This is the Boston community and our 2 best hospitals, arguably. And we didn't even know about it. And it was only when, after the fact, we looked at it through these tools that we could see it. Unfortunately, there's worse to say. We shot down those 700 planes. This is Vioxx coming in. That's Vioxx coming off. And when we case control it, that's Vioxx, a drug given for pain, which is a very good drug if you have arthritis and it got slammed in many ways because it got oversold. That drug nationwide caused heart attacks, but we didn't have to wait for the FDA or anybody to tell us. We could have seen it in our own data. And I can tell you, someone did look at that data early on. So, do I have a pointer here? So, around here, Kaiser Permanente looked at their data and they said, it doesn't look good, and there's a few papers coming out that says maybe it causes heart attacks. Let's take it off our formulary. We will not give it to our patients. The rest of us, Harvard hospitals, most of the United States, most of the world, kept on giving. Tens of thousands of people had heart attacks, death, unnecessarily. That's the state of medicine today. Think about that. And you can say, Zach, that's all well good, that's after the fact. There's another drug where we were in the heat of battle. There was a drug called Avandia, still exists, rosiglitazone, an oral hypoglycemic agent. And it's used for diabetes. And there was some controversy, does it cause more heart attacks than other drugs in the same class? And we looked again at our data, and we saw, sure enough, compared to another drug with exactly the same mechanism, pioglitazone, so this is rosiglitazone versus pioglitazone, 50% increase in heart attacks. We immediately stopped prescribing it. The FDA cited us, and as one of 4 papers black boxing it. And I want to point out something. I'm not a pharmacokinetics person. I am not a pharmacovigilance person. We were building infrastructure to study healthcare systems. And in the process, just to show that we could do it, we said, well, what can we say about this controversy in real time? And we sort of accidentally published this paper. So ask yourself the question, is this being done today by hospitals? Are we now looking for all new drugs that come out at each hospital? Of course, the answer is no. So just so you orient yourself about what rocks or tomatoes to throw at me, I work both sides of the street. I have a PhD in computer science, and I'm also trained as a pediatric endocrinologist. And so I can tell you that fundamentally, leadership in medicine doesn't understand this. Now, some people understand it. That's why we created this department. But I'm telling you, the opportunity, except in the ways I will talk to you about soon, enabled by you and your colleagues, are beginning to help. But it's important for you to realize that we don't have even basic air traffic control. Planes are crashing, we don't even know it. Sometimes we actually shot them down. That's the state of medicine today. But I want to point out, without the help of health IT colleagues across our hospitals and the medical school, we could not even have done these studies. Here's another study that we did using this infrastructure. This is one patient. In this complicated radar plot, it's one patient coming into the healthcare system at the center. And I've rolled up all the different fancy medical-sounding diagnoses into these broad, simpler diagnoses. And so every time the patient has an injury, put a dot here. Every time there's a urinary problem here, a gastroenterological problem, put a dot there. And as they get closer to the present, they're closer to the periphery. Now, I've asked this question of maybe 1,500 very sophisticated medical audiences, and they always get it wrong. So I'm just going to give you a quick shout-out opportunity, because you can't get it worse than the doctors. What do you think the diagnosis is of this patient? Be bold, come on. No, you can't do worse than the doctors. I'm waiting. I can't hear what you're saying. Okay, that's not bad. That's not bad. That's not fibromyalgia. It's not great because sometimes fibromyalgia means pains and I don't know why. Average answer for doctors is Munchausen syndrome, which is incredibly cynical because it means people are talking about symptoms to get attention. That's the average doctor response. No, what this is domestic abuse. And we ran this across all patients, across all hospital systems in Massachusetts. Just looking at discharges from Massachusetts, we were able to detect domestic abuse on average 2 years before the healthcare system was aware of it. This in a system where you ask every patient, are you safe at home? Even so, we could detect domestic abuse on average 2 years before, sometimes up to 6 years in advance. So that's the power of our data. Whoa, sorry. That's the power of our data working for us. Ask yourself, we published this in the British Medical Journal in 2009, very fine journal. Is this being used anywhere today? No. We'll get to what the problems are. But the problem is, on the upside, if we have control over data, as we have with I2B2, we can see these things. And I could, if I was a venture capitalist, I could give you all sorts of fancy reasons why we worked well. But the fact is, and we used in this case a naive Bayes predictor, but who cares? I will hypothesize if I showed the doctor just a plot of all those events, they'd figure it out. But no doctor in that 30-minute visit has the time to go through all 60 visits or through whether in paper or on the electronic medical record. All right, I was visited maybe 6 months ago by a very glib, smart, fast-talking, former MIT undergrad, now Silicon Valley CEO, data scientist. Already made a lot of money, got a nice B-series round of financing on their startup. And he was telling me all the great things they were doing with their data, with Google, with our Blue Cross Blue Shield, to help us. I said, that's really interesting. Let me show you some data that we have from our hospitals. Let's just take men who are unfortunately as old as I am, between 50 and 69. And we've done this for every single blood test. There's something like 6,000 different blood tests that you can do in the average hospital. But let's just, and we've done this for all of them, but let's look at just one, white blood count. And let's say that you're this age. What's your chance of dying in the next 3 years? Cheery thought. So it turns out, if you have a low white blood count between 12 a.m. and 8 a.m., your chance of dying is higher than 50%. But if it's between 8 a.m. and 4 p.m., your chance of dying is only 3%. So I told to this smart, fast-talking Silicon Valley data science monger, why do you think this is happening? And they said, circadian rhythm? I said, nice try. It's very simple. Here, if a doctor comes to you at 3 o'clock in the morning to draw your blood, they're not stabbing you to wake you up. They're stabbing because they're really, really worried about you. You're really, really sick. As opposed to if they're drawing the blood at 8 o'clock in the morning or 9 o'clock in the morning, it's just a routine check. And if you're a data scientist and you don't care about how the data is obtained, those things look like the same. So that looks like noise. And so there's really two sets of physiologies here, the physiology of the patients and the physiology of the healthcare system. What do doctors do and nurses do, and when do they do it? And you have to know both to actually be able to actually provide care. But if you're a data scientist for which data is all the same, you're going to miss that completely. He was a little bit horrified when I showed him that. He said, we have to go back and work on some things. Because of course, this affects his ability to predict. And so the point is, working with, and this you will see in every domain, with our different schools about what they know well is going to allow them to outperform any analytic process that ignores that domain-specific knowledge. So I have an aspiration. Aspiration goes something like this. Now, about half of you seem old enough to know what the hell I'm talking about when I say, if you liked Pretty Woman, you probably like An Officer and a Gentleman. And if you liked An Officer and Gentleman, you probably liked American Gigolo. And that's not because they all have Richard Gere in them. It's because Netflix has figured out that's what you'd like. Now, how does Netflix do this? Well, let me back into it. When's the last time you went to the doctor and you were confident that the doctor knew your entire previous medical history? When's the last time you went to the doctor and you were confident that they knew the entire medical history of all other patients similar to you? Forget the whole world, just in their own practice. How confident were you in that? How confident were you that they had made all their data available to a statistician, data scientist, to actually predict what's the most likely thing to happen to you next? I think the answer to all of those three questions is not confident at all. And yet, what Netflix did, it looks at all your viewing history, it looks at all the viewing history of everybody who clusters with you based on what their previous selections are, and they made the all that data available to data nerds like myself in competition, say, can you do a better job of predicting what people like? And it got better. This is not happening in medicine. And so it is a sad comment to say it'll be a great day when medical prognostics are as good as Netflix. Think about that. But part of the key to that is going to be to make the data available so we can actually come up with objective functions, so we can actually train it and say, what is the function that, in this case, let's say, minimizes morbidity and maximizes enjoyment or health. And we could actually do that, but for the most part, we're missing data. We can't even begin to start. So this is a very old slide, and it's out of date in the sense that there should be now about 130 points on this map. This is all the implementations of this I2B2, Informatics for Integrating Biology in the Bedside. In a nutshell, it's a free and open source software that takes data out of electronic health record systems where it's been locked up, sort of a one-way bit bucket, and make it available for researchers. And it's free and open source, but it's free like a pony. You have to feed it, and you have to clean up after it. And so, I mean, literally it means that there's $1 million of IT staff minimum that you need to make this installed and feed. Nonetheless, people have done this, and we outcompeted all the vendors unintentionally. Microsoft with their Amalgam platform, a bunch of EHR vendors, and it's been widely adopted because A, it works, B, it's made an open source community that continues improving the product. And we're going to have our national academic users group meeting at Harvard next month. This month. And so, as a result, we're able to now do queries across multiple systems that have adopted these data. Now, let me just tell you a truism, which you can now think of as Zach's axiom. The closer two hospitals, the more they mutually loathe each other. So you can imagine that when I proposed to the CEOs and senior vice presidents of the hospitals that we're going to have a distributed system across all the Harvard hospitals, I got a lot of yelling on my mobile phone, and I remember it well. But nonetheless, in fairness, everybody decided to play ball, and it allowed us to do an amazing set of things. What we did, for example, is we said, we're going to do real-time checking to see if you're employed by the hospital, so you're employed and therefore covered by all the HIPAA rules, and you can be fired, to make sure that you're on the Harvard faculty or a fellow, and make sure that in real time that your research credentials are up to date. Do you know, I think there were at least 12 different administrative systems that we had to go up against real time to make that happen. But in this room are representatives of several groups that made it happen, and we all got it done within a year. And so that enabled the following to happen, since we said now it's free and available to all researchers at the medical school and affiliated hospitals, literally tens of thousands, we're able to do a bunch of studies. Now, one such study I want to point out is this rheumatoid arthritis. And rheumatoid arthritis has a hereditary component. If your family has it, you're more likely to have it yourself. And so here are a bunch of genetic markers. And what we were able to show, and here on the y-axis is, if you have this genetic marker, what's your risk of having rheumatoid arthritis? And we were able to show, first of all, how do we know these patients had rheumatoid arthritis? By doing natural language processing on the electronic medical record, and then using the discarded samples of those same patients to look at their genetics. Shown in blue dots were the risks for individuals based on a multi-million-dollar, multi-year study. We were able to redo the whole study at 1% of the cost and about 10% of the time, just using our IT systems and reproducing it pretty well, as shown by these red dots. But I want to make 2 points. Half of the time, when we found that there was a billing code for rheumatoid arthritis, the patient did not have rheumatoid arthritis. We were able to see through natural language processing, through reading of the record, automatically, that patient did not have rheumatoid arthritis. And that just surfaces something that everybody knows, which is Billing codes are about billing. They're about reimbursement, of getting more money to this healthcare system. And yet, this is what drives national policy. So all our big policies are based on things that are way off, in this case by a factor of 2, because we're looking at the billing codes. And this surfaced that, and so because we don't want to spend our pennies on genomics on the wrong patients, it showed us very clearly that only half the patients we thought had rheumatoid arthritis did. Furthermore, who does not get studied typically in genetic studies? Underrepresented minorities. But African Americans, Hispanics. But because these patients in our healthcare system come from all backgrounds, we were able to rerun the study literally at the press of a button and say, what are the risk factors that are different in genetics for Hispanic Americans and African Americans? And that's the power of being able to look systematically at the data. And so concerns that have been raised are, like I told you, who will see the data? We can secure it, but can others see it? What will they say about us? Every time, I cannot tell you, it's a reflex I think that every well-meaning CIO has in this city. What will the Boston Globe say about this if we do it? And I have to tell you that when we first proposed the I2B2 system back in 2004, there really was a front page cover story in the Globe on the front page about this, Kohane, blah, 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 tens of millions of records. Fortunately, we had, through your efforts, done everything with a higher level of security than anything else done in the country. So when they interviewed people around the country, they said, oh yeah, that's better than anything we're doing. And they only had good things to say in that report. So the narcissistic side of me, which unfortunately is bigger than I would like, I've organized Google alerts. So every time something that I've done is cited, I get an alert. So I said, what's this alert? It's about something called the Shared Health Research Information Network, SHRINE. So this is a system that brought together those so-collegial hospitals across Harvard into this one network. And I said, so what's this about SHRINE? So it turns out, unbeknownst to me, as it was designed, some young researchers at Beth Israel were studying a disease that kills women in their 3rd trimester. It's called peripartum cardiomyopathy. And they'd come up with a mechanism around the imbalance of the development in blood vessels and the regulation of blood vessels that seemed to be causing that. But they had only about a handful of patients, and that was just not enough to validate their findings. And so without asking us, as we had designed it, they went and used the SHRINE system, and they found on the order of 6 or 7 handfuls of patients across the 6 million patients in our combined database, distributed database. And they were able to validate their findings, and they published it in Nature. So I wanted you to think about what happened. They had these young researchers who had a good scientific hypothesis that ended up being proven out. But if they hadn't had the system that you had enabled with the governance and the security infrastructure, it would have taken them somewhere between years to never to actually implement. Because a young investigator has neither the time to hunt through all those millions of records, nor the standing to go and say to everybody, show me your data. So building these platforms that allow sharing is absolutely key to the success. And it does involve some painful and boring conversations about governance, but they're, in the end, well worthwhile, as I think examples like these show you, and we have many of them. But I want to point out, this was not yet cloud hosting. I had decided, for a variety of reasons, which I'm sure you'll understand, that at that point in time, this was a decision made back in 2005, 2006, we were going to leave all the data at their source hospitals because we didn't want to deal with the politics of putting it into a single combined database. So what about hosting it by a third party? So, yeah. Okay, so for those of you who are nerds will understand that. For the rest of you, forget it. But certainly every time I talked about cloud hosting in 2006, 2007, 2008, it was like a what are you talking about moment. And I stopped talking about it, frankly, until Reiner brought it back into the vernacular of the medical school so you could talk about it without sounding like an idiot. So what are the drivers now for the use of the cloud, third-party hosting? So I'm going to start a little bit historically. It's still, every time I say this, I'm still astounded by it. This happened in the 1940s in England. A woman could be delivered on Monday, happy and well with her newborn baby on Tuesday, feverish and ill by Wednesday evening, delirious and in agony with peritonitis on Thursday, and dead on Friday or Saturday. So these are due to infections that happen relative to pregnancy, and astoundingly, even in the early part of the 20th century, in first world countries like England, there was a 2 to 3% death rate, which meant 2 to 3% of homes were missing a mother or a wife because of these infections, which unfortunately, by the way, were also helped by doctors not washing their hands as they went from pregnancy to pregnancy. But the real reason I'm pointing this out is that the first successful treatment of this happened in 1944 with penicillin. But penicillin was discovered in 1927. There was a huge gap between 27 and 1944. And yet, and you can say, well, that's really old history. And yet, we're at the same crux today. There are these terrible diseases like lung cancer and melanoma, which, unfortunately, if you have them today, you should be worried a lot, unfortunately, about the next few years. However, there's amazing drugs that have just been developed, which are making us think very differently about cancer. These so-called checkpoint inhibitors, which allow the immune system to actually figure out who friend and foe is much more effectively. And by and large, they seem to have changed the prediction for death for these patients, and not change it in the typical way by a few days, but by a few months. But, as shown in this Wall Street Journal article, there are some who didn't get their lives prolonged by a few months. They were totally cured. Totally cured. The cancer went away, just dissolved. And these are cancers that we'd throw everything against them, and nothing would happen. These are actual cures. We've never seen them before, anything like this. But here's the rub. They're the tiny minority. And so here's the challenge. Who's studying them together to actually understand what's going on? Each drug company has a few of these patients in a few hospitals. Is anybody bringing them together across the nation to understand what's the underlying biology that's actually making these patients respond? No one's doing it, but that's a central challenge for us. And we already have the tools. And in many ways, as I'll describe for the Undiagnosed Disease Network, you have helped build an infrastructure that today could help answer that question for these patients. But it really is a leadership and governance question, which is where you help us every day. And to just give you a feeling of how possible this is, by the way, I'm going to do a check because I really don't want to get the other finger broken. And I see it's 10:18. How much time do I have? 10 more? All right. Not very generous. Okay. You're talking, it was a movie. All right. Okay. So this man is a very important person, Matt Might. He's a computer scientist. And about 8 years ago, his first of 3 children was born and looked a little floppy. And he was a computer scientist just joining his tenure-track job in University of Utah after having trained at Georgia Tech. And his first child born, a little floppy, then developed some seizures, not developing milestones correctly, multiple diagnoses made at University of Utah, which has a first-rate genetics department. And they say, this gene is affected. They do the test. No, it's not. So multiple diagnoses all go wrong. He takes matters into his own hands. He does a few things. First of all, he goes through his social network and says, who is looking at every gene? So back at that time, not everybody was doing this. So he finds David Goldstein at Duke and does an exome sequence, which is the protein coding part of the genome. And they find that his child has a mutation in a gene that no one had ever heard of associated with disease, NGLY1. So, and they prove that this is in fact the causative mutation. So what's going on here? You have a child who has the first diagnosis of that disease ever. No one's ever been diagnosed as having disease associated with that. And now the child is having 100 seizures a day and not responding to anything. So what does he do next? Well, first he has, among computer science nerds, he had a well-respected blog. He's mostly in cybersecurity and languages. And it shows a picture in his blog of Liam Neeson with a gun pointed at the camera, and it says, I was looking for the killer of my child. And then you read on, and it was me. because, of course, it was his genetic variants and that of his wife, which caused the disease in his child. So that got a lot of attention. But then he went a step further. So I think most of you know that you can buy Google AdWords, and if they're porn words, pornography words, it costs dollars to rent a word every time it's hit. But if it's a very rare word, like in this case of his child had no tears. And so if you say elacrima, no tears, no one cares about that. And so it costs a cent, 1 cent to put that out. And so what he did is he rented out all those words, seizures, elacrima, developmental delay, and within 1 year, he had 50 families that not only had the same symptoms in their child, but were shown to have the same mutation. Think about that. I don't know very many doctors who have discovered a disease. He had. I don't know many doctors who have been able to find a whole research cohort of 50, because that's what you need when you want to study it. He had. And he was using the information tools that you are very aware of. And then, as he talks very public about at a symposium, a precision medicine symposium that I host, and I'll tell you about the next one we're hosting on the 22nd of this month, he talks about the fact that he had only 6 weeks of high school biology. But it's his kid, he's studying really hard, he's a smart guy. And he figures out, talking to specialists in the functioning of this gene, that maybe it's a problem with a type of sugar not being clipped off a protein in the brain. And so he looks up the sugar, and sure enough, it's available on Amazon.com. So he orders a few pounds of it for a couple dollars, makes himself a shake, drinks it, doesn't die. Next day, he gives it to his kid. By the way, he said this right most recently in front of the FDA commissioner, who blanched. But nonetheless, this is really what he did. And so he gives it to his kid. Seizure rate goes way down, and the child cries for the first time in his life. Of course, it took a glass slide to immediately shift off the tears for study. But think about that. He's using those informational resources. And I'm saying that, and I'm focusing on this particular case because it shows you don't have to be a doctor, but you have to know about your information resources. You have to have the energy and the passion to apply them. And look what you can do. Think how much more we can do if we have our resources, the expertise, but we also apply governance, but retain the passion and the focus. And I would claim that if we can all do that, then we can take what Mike does and really apply it at a much larger scale. And this is the whole precision medicine idea. We can find out all the individual cases and try find out what's the right way to treat them. So how do we do this? How do we do this at scale? How do we get all the data for cases like Matt might? I think I want to fast forward past slides because I just can't talk about it, given the time, because I really don't want to get finger broken by Anne. Yeah, I was just going to talk about how to create an app infrastructure on top of electronic health records. But I'm going to talk about go back to Matt's story. Yes. So keep in mind Matt's story. And something happened around 2013. One of my close friends and colleagues, Eric Paraxlis, former CIO at Johnson & Johnson, then CIO at the Food and Drug Administration, joined the Center of Biomedical Informatics in a very selfless way because he wanted to help us become a department. He himself, by the way, is a very public cancer survivor and helps organizations bring data together. And Eric had worked at CIO FDA, so the FDA site gets literally tens of thousands of attacks on it per second from China, from everywhere. Because his job is not at FDA. Remember, it's not just drugs, it's food. They have to know every container that's coming in, does it have a radioactive substance in it, or does it have those same fish from that Southeast Asian country that were rotten last time? He has to be tracking all of that. And so he was very, very aware what the state was of cyber threat. And he looked, as he came to me, at what the hospitals had, and he said, Zach, they're extremely vulnerable. They're incredibly vulnerable. They're wide open, in fact. Whereas I was talking to all my CIO friends, like John Halamka, former student, Dan Nygren at Children's, former student, and they were saying, no, we've got this under control. And so he wrote this article in New England Journal of Medicine saying, we've got a threat today. And at the same time he started writing it, Children's Hospital actually was threatened because of a controversy around the family. Anonymous said, we're going to take you down. And you know what? They actually did. And Children's Hospital went offline and kind of got penetrated. And so all of a sudden, this caused a change in thinking. It was the existence proof that our health IT systems were not that secure. And by the way, there's a reason for that. It's because our health IT systems are state-of-the-art for approximately 1980. Which means that all the device drivers and so on are often legacy, and the patches don't exist. In fact, the only thing that protects them, some of them are so old that no one even knows that they exist, and so there's no scripts to hack them. But a lot of them do have these vulnerabilities. And so this allowed an opening to start saying, you know, maybe it is more secure. You know, Target got hacked, and Target had its data available on its own servers. And it became clear that the hosted sites were more secure. This study, by the way, shows that, you know, I'm sure you've been subject to phishing attacks when people come to you and say, oh, your cousin's so-and-so is in an accident and we need you to send their credit card. And they know lots of things about you. And then they induce you to do something rash and stupid, like give a credit card or send a payment. People do this all the time. Now, which is the richest source of that data? It's health record data. And this recent study shows that enormous percentage of the breaches, phishing breaches, come from data obtained from healthcare systems. So healthcare systems are a conduit to breaches into the rest of the IT ecosystem. So we proposed, as you'll see, a completely different model where we're going to hold data across multiple institutions, not in distributed fashion, but co-located in a professionally managed third-party service. And there's various levels of data security. There is actually one level 5 security application at Harvard, and when you're level 5 security, there is no connection with the internet. There's a spark gap between you and the internet. And it's one very Trump-compliant database. It's a study done by one of our sociology researchers about migrant movement across the border. But we were level 4. And in order to have that conversation, we needed to have the CIOs at the hospitals, the CIO of Harvard Medical School, and the CIO of Harvard University all behind us. And all the security teams involved, many of which are here. And they did work which I don't know if people appreciate, has been done in very few other institutions. When I present the work that I'm about to show you, that we're able to safely host in a HIPAA-controlled manner, covered manner, data on the cloud, it's news to people at NIH, it's news to people at multiple institutions. They're envious. And so although we'd like to, be frustrated by all the things that we'd like to do, we haven't done, we should pat ourselves on the back that our teams here enabled this to happen. So what did we do? We signed a business associate agreement with heavy lifting by Ann and others. We have dedicated instances on Amazon Web Services, and because we're cheap, we put everything onto one account, and everything is encrypted, even before sending data. And everything is audited. And you know what? By doing this, we are so way ahead of any standard of care of health data that this is now the standard to meet for all other federal applications. And so we are now hosting a lot of registries of very sensitive, rare patient data for NIH using this infrastructure that we've hosted. They said to us, we'd rather that you host it than us because we don't know how to do this. And it's really plug and play. For each one, every time we want to spin up one of these registries, press a button, load the data in, and it's going, and it's accessible today. I'm going to move past this because, again, that pinky doesn't want to be broken. So I'm going to end with the Undiagnosed Disease Network. So there is a program at NIH called the Undiagnosed Disease Program, where patients, and you know some of these patients, some of them in your family, who have gone on for decades without being diagnosed. Some only for years, but they're dying rapidly. So they created a program at NIH where they would sequence your genome and find the best doctor/specialist for you in the Bethesda area. And it was amazingly successful. After not being diagnosed for years, 60% of these patients were diagnosed. And it was so successful that in 2011, there was bipartisan support, Republicans and Democrats, to create a $250 million national network so that all these 7 academic health centers could receive patients that we, through the Department of Biomedical Informatics, would host the data in the Amazon cloud. And so as a patient, you come to the portal, and you'd be triaged to one of these 7 large academic health centers, your genome, and you'd be sent to the right hospital, coast to coast, with your genome and your data showing up with you. When has ever your data shown up with you at the doctor, where they don't have to ask everything again? And for these patients, it's all being done. And it only took us 13 months. We got the whole system live nationally with your help. And starting May of last year, patients started lining up. We've already 100 patients gone through, and many new diagnoses made because you enabled this to happen. This is not just some sterile academic exercise. We have real patients that have been diagnosed after years of without diagnosis because we made this happen. One last slide. What is this thing? Looks like Fitbit colors. It is Fitbit. And it's not my heart rate. It's not even my weight. It's my mother's weight. And so I bought her a scale, an area scale, which plugs in wirelessly into the cloud. And up to Fitbit cloud, every day I see her weight. And what do? She's 89 years old and refuses to move in with me, so pretty independent. But her weight, as you say, blips up, and that's a fast weight. That's not from eating well. That's from water coming on board from heart failure. She has a little bit of heart failure. So it's very simple. I just tell her, help her, just give her another dose of this diuretic, and the water comes out. You know what this means? It means we go on for months without ever having to go to the hospital. If you did not intervene at that point, the water would keep on landing up, your lungs would flood, and you'd be in the hospital. And just by having all this data securely on the cloud, it's trivial to manage my mom. So this really is going to impact us in many ways. And so with that, I just want to thank you. There's lots of players which I haven't shown, but I want to say, for all the things I've shown, these are all the IT staffs that actually have played significant transformative roles in this. And if you want to hear more of this, go look at bit.ly Rogue Therapeutics, about a conference that's available to all of you, where you'll hear more about some of these patient-driven stories. And with that, thank you very much.